Hello, my name is Brandon Sonn. I'm a PhD candidate at the University of Colorado, Denver, and I want to thank you for taking the time to watch my presentation about the metabolomic markers predictive of adverse events due to acetaminophen administration. Briefly, neither myself nor any of the other authors have any conflicts of interest to disclose. Acetaminophen is a medication that is administered, prescribed, and consumed in hundreds of millions of doses annually. And despite this, drug-induced liver injury, or DILI, can occur either with therapeutic and or overdosing. This was a secondary analysis of a randomized control trial looking at the max recommended acetaminophen dose administered to subjects daily for at least 16 days, which was 4 grams per day. And inclusion criteria included adults with no history of hepatic damage or significant alcohol abuse or recent acetaminophen use that were able to provide informed consent. At each of the study visits, days 0, 4, 7, 10, 16, 31, demographics, alcohol use, medication use were collected, as well as serum. For this metabolomics study, we are looking at samples from days 0, 7, or 10, 16, and 31. After metabolite extraction, we ran these samples on ultra-high performance liquid chromatography mass spectrometry, and then performed a plethora of statistical analyses to identify significant differences between our populations. Our population included 204 patients in total, which included 25 within the ALT elevation group, as defined by at any study point having an ALT greater than 60 international units per liter. So you can see the majority of our population fell into the no ALT elevation category, were female, Caucasians, non-Hispanic, in their 30s, but all genders and races were represented. Relevant clinical data is that at baseline, both the alanine transaminase, or ALT, as well as alkaline phosphatase, or ALK-PHOS, were significant between these two populations. This would be our ANOVA simultaneous comparison analysis graph that is a multivariate analysis using both leverage and squared prediction error to identify metabolites significantly modeled within this analysis. Increased leverage is equated to the increased importance of the metabolite within this model, and a decreased squared prediction error is associated with importance and relevance of the metabolite being included. With the comparison of our ALT elevation versus no ALT elevation groups, we identified 4 metabolites that were well modeled, 2 within the urea cycle and 2 that were associated with glutathione metabolism. Looking at the interaction between ALT classification and the time series, we identified 5 additional metabolites that were significant, which included glutathione, 2 metabolites related to starch metabolism, and 2 related to fatty acid oxidation. Next, we performed a partially squared discriminant analysis on the entire cohort at day 0, so pre-acetaminophen treatment, to identify distinct metabolomes between those with an ALT elevation and those without an ALT elevation. And you can see that there was a distinct pattern. 2 metabolites that showed up as significantly different, elevated in the population with ALT elevation, were ornithine and allantoate, that are both associated with urea production. Overall, here is a pathway analysis that looks at the combination and linkage between the urea cycle and the glutathione metabolism cycle. In this study, we identified 3 metabolites that were associated with the urea cycle that came out as significant within our analyses, as well as 3 different metabolites that were significant within the glutathione metabolism pathway. As a key point, ornithine and glutamine were the key metabolites that linked these 2 pathways. Next, we had acetaminophen-related ALT elevation predictors. So this was, again, at the day 0 entire cohort population. We identified that both the ALT and the alkaline phosphatase were significantly elevated in the ALT elevation group compared with the no ALT elevation group prior to acetaminophen administration, even though all of these levels were still considered to be within normal reference ranges. Additionally, ornithine was significantly elevated within the ALT elevation population. So using a multinomial logistic regression, all of these metabolites remained significant at a p-value of less than 0.05. And when we conducted a ROC curve, we got a value of 0.8 with a confidence interval of 0.7 to 0.9. Concluding thoughts is that we have identified that there is a relevance of both the urea cycle and glutathione metabolism in acetaminophen in response. And then we have also identified that there are markers predictive of ALT elevation in patients taking therapeutic doses of acetaminophen, and those include alanine transaminase, alkaline phosphatase, and ornithine. This study did have pertinent limitations, including a lower population of patients in the ALT elevation and accounting for demographic lifestyles. Next steps would be to run isotopically labeled standards for urea cycle metabolisms and increase a better washout period for subjects. And thank you to my group.